Disseminated intravascular coagulation. Summary. Definition. A complex disorder characterized by widespread clot formation within small blood vessels leading to organ dysfunction, severe bleeding, and thrombosis due to excessive consumption and subsequent depletion of platelets and clotting factors. Etiology. Infections, particularly sepsis, often with gram-negative organisms. Trauma, including acute traumatic coagulopathy. Obstetric complications, such as amniotic fluid embolism, severe preeclampsia. Malignancies, especially those associated with increased procoagulant activity. Others, significant liver disease, immunologic reactions, and massive transfusions. Pathophysiology, initiation by a trigger, e.g. infection, trauma, leading to systemic activation of coagulation. Formation of microthrombi causing organ damage and consumption of clotting factors and platelets. Secondary hyperfibrinolysis, leading to bleeding. Clinical features: bleeding, hematuria, petechiae, purpura, ecchymoses, bleeding from venipuncture sites. Organ failure, secondary to microthrombi causing ischemia and dysfunction, e.g. acute kidney injury, respiratory distress. Diagnostics: coagulation panel, prolonged PT and APTT, decreased fibrinogen, elevated D-dimer. CBC, thrombocytopenia with or without schistocytes on blood smear. Diagnosis involves a combination of clinical presentation and lab findings. Treatment: address underlying cause, e.g. antibiotics for sepsis, control of hemorrhage. Supportive care with blood products as needed, platelets, fresh frozen plasma, cryoprecipitate. Consideration of anticoagulants or antifibrinolytics in specific cases. Close monitoring and specialist consultation. Differential diagnoses: thrombotic microangiopathy, TMA, including TTP, HUS, and HELP syndrome, characterized by severe thrombocytopenia but normal coagulation times. Heparin-induced thrombocytopenia, IT, thrombocytopenia with or without thrombosis, typically following heparin exposure. Immune thrombocytopenic purpura, ITP, isolated thrombocytopenia without the coagulation abnormalities seen in DIC. Liver disease and vitamin K deficiency can mimic DIC with abnormal coagulation tests, but usually have distinct clinical and laboratory profiles. Clinical case: disseminated intravascular coagulation. Patient profile: age, 45 years. Gender, male. Medical history: previously healthy, no significant medical history. Presenting complaint: the patient presents to the emergency department with complaints of sudden onset of widespread purpuric rash and uncontrolled bleeding from a minor laceration on his hand. He also reports feeling unusually fatigued and has noticed dark urine since the morning. Clinical examination: vital signs: BP 160 mm Hg, HR 110 BPM, temp 38.5 Celsius, 1 RR 22 min. Skin: widespread purpura and petechiae, especially on the lower limbs and trunk. Cardiovascular: tachycardic, no murmurs. Respiratory: clear to auscultation bilaterally. Abdomen: soft, non-tender, no hepatosplenomegaly. Neurological: alert and oriented, no focal deficits. Laboratory findings: CBC, hemoglobin 12 grams per deciliter, platelets 25 of 10 to 9 milli, WBC 18 by 10 to 9 milli. Coagulation panel: PT 18 seconds, normal 11 to 14, APTT 45 seconds, normal 30 to 40, fibrinogen 150 milligram per deciliter, normal 200 to 400, D-dimer 5,000 nanogram a milliliter, normal 500. Biochemistry: creatinine 1.8 milligrams per deciliter, increase from baseline, bilirubin 2.2 milligrams per deciliter, LDH elevated. Imaging: chest X-ray, clear lung fields, no cardiomegaly. Abdominal ultrasound: normal liver and spleen size, no ascites. Clinical course: the patient was admitted to the intensive care unit due to concerns for sepsis and disseminated intravascular coagulation. Broad-spectrum antibiotics were initiated while awaiting blood culture results. Transfusions of packed red blood cells, platelets, and fresh frozen plasma were administered to manage anemia, thrombocytopenia, and coagulopathy. The patient was closely monitored for signs of organ dysfunction and supportive care measures were optimized. Differential diagnosis: sepsis-induced DIC, thrombotic microangiopathy, acute liver failure, malignancy-associated coagulopathy. Discussion points. 1. Initial management. What are the immediate priorities in managing this patient? 2. Diagnostic workup. What additional tests would you order to elucidate the underlying cause of DIC? Treatment considerations. How would you adjust treatment if the patient's renal function continues to deteriorate or if significant bleeding occurs? 4. Prognosis. Discuss the potential complications and prognosis of DIC in the context of sepsis. Hemolytic uremic syndrome. Overview. Definition. HUS is a form of thrombotic microangiopathy characterized by the triad of microangiopathic hemolytic anemia, thrombocytopenia, and acute kidney injury, AKI. Epidemiology. Predominantly affects children under 5 years old. Etiology. Commonly caused by enterohemorrhagic Escherichia coli, particularly strain O157H7, through consumption of undercooked beef or raw leafy vegetables. Pathophysiology. Infection leads to mucosal inflammation and systemic circulation of bacterial toxins, causing endothelial damage. This results in vasoconstriction, platelet aggregation, and microthrombus formation, leading to hemolysis, thrombocytopenia, and organ damage, especially in the kidneys. Clinical features. Often follows a diarrheal illness, often bloody, 5 to 10 days prior. Symptoms include petechiae, purpura, mucosal bleeding, fatigue, dyspnea, pallor, jaundice, hematuria, proteinuria, and reduced urine output. Diagnostics. Hematology. Decreased hemoglobin, haptoglobin, and platelets, increased indirect bilirubin, reticulocytes, LDH, and presence of schistocytes on blood smear. Coagulation profile. PT and APTT may be normal or slightly elevated, differentiating it from DIC. Serum chemistry. Elevated BUN and creatinine indicate impaired renal function. Differential diagnosis. Thrombotic thrombocytopenic purpura, TTP, DIC, immune thrombocytopenic purpura, ITP, Bernard-Soulier syndrome, Glanzmann thrombasthenia. Treatment. Mainly supportive care. Avoid antibiotics and antimotility agents in suspected EHEC infections as they may increase HUS risk. Plasma exchange therapy may be considered in severe cases. Key points. HUS is a critical condition requiring prompt diagnosis and supportive treatment to manage symptoms and prevent renal failure. It is essential to differentiate HUS from other similar conditions like TTP and DIC for appropriate management. Avoidance of specific medications can reduce the risk of worsening HUS in the context of EHEC infection. Clinical case, hemolytic uremic syndrome. Patient information. Age, 4 years, gender, female. Presenting complaint. The patient presents with a 2-day history of decreased urine output, marked pallor, and unexplained bruises on her legs and arms. History. The patient had a gastrointestinal illness characterized by bloody diarrhea approximately 1 week ago, which resolved spontaneously. She has since been increasingly lethargic and irritable. The family denies any recent travel, exposure to sick contacts, or consumption of undercooked foods. No known drug allergies or significant family medical history. Physical examination. General, lethargic, pale, mildly dehydrated, vital signs. BP 90, 16 mHg, 120 BPM, temp 37.2 degrees, RR 24 min. Skin, diffuse petechiae and ecchymoses on the limbs, no rash. Cardiovascular, tachycardic, normal heart sounds, no murmurs. Abdomen, soft, non-tender, no hepatosplenomegaly. Neurologic, irritable but no focal deficits or signs of meningitis. Initial laboratory findings. CBC, hemoglobin 7.5 gram liter, platelet count 40 by 10 to 9 liter, WBC 12 by 10 to 9 liter. Peripheral blood smear, schistocytes present, decreased platelets. Chemistry panel, BUN 36 mg per deciliters, creatinine 1.9 mg per delis, elevated from baseline, normal electrolytes. Coagulation profile, PT 12 sec, normal, APTT 30 sec, normal. LDH, elevated, haptoglobin, decreased. Urinalysis, hematuria, proteinuria. Imaging, renal ultrasound, normal size kidneys with increased echogenicity. Clinical course. The patient was admitted to the pediatric intensive care unit for close monitoring and supportive care. Given the clinical presentation of microangiopathic hemolytic anemia, thrombocytopenia, and acute kidney injury following a diarrheal illness, A diagnosis of HUS was strongly suspected. Intravenous hydration was initiated to support renal perfusion. Blood transfusion was considered given the significant anemia. The nephrology team was consulted early for potential renal support, including dialysis, given the acute kidney injury. Discussion points. 1. Management strategy. What is the appropriate supportive care approach for this patient? 2. Differential diagnosis. How would you differentiate HUS from other similar conditions such as TTP or DIC based on the presenting symptoms and lab findings? 3. Long-term monitoring. What are the key aspects to monitor in this patient to assess the progression or resolution of HUS? 4. Prevention and education. What advice would you provide to the family to prevent future occurrences, especially considering the patient's age and the typical etiology of HUS?